these many months and have given us so much feedback and input into how we can better serve the community. And we want to continue in that vein of having very open conversation about what needs to change, what kinds of things we should be considering as we move forward. And as always, we also use this opportunity to reimagine how we use this space and how we use our time together. And so please feel free also to share information about how we might consider using this space moving forward. It is not lost on anyone that we are, COVID is still with us, and we have a new health issue that we are also dealing with, our community is dealing with, and that's MPOX. And so there's also an ask of you to be thinking about how this space might be seen as also an opportunity to look at other health issues down the road. So with that, I would like to first start off with our partner updates. And I think that we have someone from Eden Community Church who will be presenting on some of the work that they're doing.
Yes. Hi, my name is Kimberly Victorio, and I am representing Eden Church and stepping in for Pastor Arlene, who unfortunately couldn't be here today. But I do have updates. I am the co-lead for the vaccination coalition that is going on with La Familia and also Tiburcio Vasquez. We have two different partnerships. And so in terms, we know that the new bivalent vaccine is out and is going to be available. We are also helping the Weeks pod that happens every Saturday. We're also helping out and staffing that. And so we are seeing the influx of people and the interest in actually getting the bivalent vaccine. So one of my updates was we have been talking to the community, and what we're hearing is about 50-50 from the people that we're actually interacting with. We're hearing that, yes, they're ready. They're ready to get appointments or head to their nearest clinic, wherever it's available. But we're also hearing, people that have already had a couple, or they're like, I got my initial dose, or I got my first booster and I'm okay. I'm done with vaccines. So we hear it's a mix and match of communication. So I think going forward for our strategy and how we want to continue helping the community, it's just education, letting them know what comes with the new bivalent vaccine and the benefits of, updating your immunity with the booster. So that's basically what we've been doing with both our coalitions. We just came back from making it like a community type of an event. And so we're seeing that we are doing the effort to canvas, but we are seeing less results. So we're going to start to come up with strategies on how to engage the community further, to bring them in and engage them not only with just information, but how do we get them to talk about how they feel about certain topics with COVID and then the new booster as well. So that's some of the updates that I have for you.
For that, okay. We'll see you.
So just want to remind everyone to mute yourself if you're not speaking. Thank you, Kimberly. Does anyone have any questions for Kimberly on the work that they're doing? You okay with questions, Kimberly?
Yeah, I'm okay with questions.
Great. Any questions? I don't think I can see all the hands. If anyone is raising their hand, I might not see it. Okay. All right. I have a question, and that is, are you sensing that people are interested in hearing about other health issues? And do you think that integrating conversation around other health issues might create more space for people to circle back around COVID. If it, because I've heard, people feel that it's sometimes we only want to talk about COVID and they want to talk about other things.
Yeah.
Kind of thing. What are your thoughts about that?
Yeah, I definitely have heard it from my team, who are most of the time they're out there canvassing and getting these questions from the community. And so there have been instances where people, other than COVID, they talk about, Mpox, or how do I get the vaccine, or what other information that we have. So I think it would be relevant to have like an arsenal of things that we can talk about with people that are not COVID related, because we know sometimes they hear COVID and they just automatically not paying attention. But if we bring up maybe other issues that people might be interested in, I think that would be a good way to engage the community.
Mm-hmm. Yeah, I think so too. I saw your hand go up. Dr. Bruce, Bruce agrees on that front. Other thoughts or questions for Kimberly? Okay. Well, I'm looking forward to us having more conversation about how we all can begin really integrating COVID into all of the health issues that we work with people around, and expanding what we engage people around. We have an opportunity right now, all of us, to really engage people in health maintenance and health promotion around a broad range of issues. COVID is not the only health issue that people are struggling with right now, and neither is it just monkeypox, mpox, that we still are struggling with chronic diseases. We are still struggling with HIV. We are still struggling with a range of things. And so there's a lot of work for all of us to do. So I really appreciate what you guys are doing. Nestor Castillo.
I don't ask too many questions often in this group, but I'm hoping it's okay to ask Kimberly and maybe other of the partners here, how has the canvassing or direct contact with residents look like for Mpox, right? What does that look like? I know that there was a vaccine for Mpox in Hayward that just recently started. So I'm just curious to hear how that outreach is going and how some of that information is getting out to community.
Oh, thank you for your question, Nestor. I think mainly for our team at Eden, I know that La Familia just recently opened their clinic every Thursday, and SkyWest specifically for Mpox. So they might have a little more information in the tactics of how to engage people with community members that actually have Mpox. But for us, it's more of curiosity based. We talk to people and they're curious to know what Mpox is, or they're like, hey, maybe they're not contacts, but they're like, maybe I know someone that might have been, that extended relation that just gets them a little more curious to learn about what entails Mpox, or like what are the symptoms and how to better take care of the people around you. So from us, it's mainly like curiosity based and people trying to gain more knowledge from it. But Erin probably has a little bit more of the technical information.
Go ahead.
Hey, team. I'm sorry. Okay. Hey, team. Erin Ortiz, CEO of La Familia. Good to be here. Thank you, Kimberly. Thank you to Eden for being a great partner. So a few things in regards to MPX. We did roll it out just recently. It is on Thursdays. And we're starting to do a lot of outreach on our social media, also in the Eden area, in the unincorporated areas, and getting the word out there. I think a lot of people don't know that it's actually a vaccine that they can get out there. And, for us, in particular in Alameda County, if the numbers still stand, about close to 47% of the people who are testing positive are Latino. So it's front and center for the work that we want to do and get out to the community. And we're just beginning the outreach. We're doing it through our street teams. We're doing it through our partners. We're working with different organizations that do specific work with LGBTQ community members. And that's what we're working on right now. So I think that in the next 2 weeks or so, we're really going to start seeing a lot more community members at our clinics to give them the MPX vaccine. So that's where we're at. I mean, we're barely rolling it out. I think because it's on such short demand, and also the way we had to kind of adjust as a clinic and really give it out. And I don't have my medical director here with me today, but we had to extend the amount that we had and approach it differently in how we give it out to the community. So that's one thing that we had to adjust for, just so we can make the vaccine, get out to more community members. So that's one area. In regards to the new booster, we got it today. We got 300. I want to say 300 Pfizer and 200 Moderna. I think a lot of people have been waiting for the new booster, and that's the information, anecdotal information that we've got. But also, a lot of people have asked us, "Oh no, we're waiting for that new one. We're waiting for that new booster." And I'm speaking totally in layman terms here, but that's essentially what a lot of people have been waiting for. So they're getting ready for the fall, and I think it's going to be an interesting period for us to read in regards to the data, and also what happens in the next 2 to 3 months. If we look at the Spanish flu, the third year in the Spanish flu was one of the deadliest. And if we look at the numbers in how we look at positivity rates in the fall, it's twice the numbers of the summertime. So I'm curious to see what happens if we end up going into an endemic in January or February of next year, or if those numbers really hike up in a way that may or may not be controllable. So it's going to be extremely interesting, to say the least. So I'll pause there.
Thank you, Aaron. We'll take one more comment and then go to our update from Doctors Dunn and Moss. Elena Lepe. Elena, your hand is up.
Hello.
Hello.
Hi.
Hi.
Hi. Good afternoon. My name is Elena Lepe, El Puente Comunitario. Thank you for sharing this information. The Finally La Familia work very hard in the community. I working in the community on outreach, share the COVID test. Finally now I have a lot of families have the three vaccination. We need the 4, I think. For all people, no one attend. So I can refer all sites, but I provide the COVID test and include especially for schools. A lot of students have positive every week. The problem is now I think the education and location. Some people or some families or some parents no one take the vaccine, especially for age 4 to 7. I think it's more important, more education for people. I help in education for my teams. Puente Comunitario working in the place, in the park, and last time in summer programs. Now in the school, so it is hard. This week I give you maybe 2,000 tests, the COVID test free for every families in the community and the school. I think it's possible you support other program for education, more education for get more vaccination. Now the other concern is for the monkeypox. So a lot of families very confused. So the question is, I need a test for this part, or I need a vaccine. If you have vaccination ready, what is next step? So it's two issues now. One people is need more education for families for in vaccination families. Another is support or more education for monkeypox. That's just my comment. So thank you. The finalists work in the community and help the parents and the community for need, I think, more support or more funds for education families and source resources. So especially for homeless people. So thank you.
Thank you, Elena, for your comments and for the work that you're doing in the community. I'm going to now turn it over to Dr. Moss to give an update on all things COVID.
Thanks, Director Watkins-Tart, and good afternoon, everyone. Apologies, I'm not on camera. I haven't quite made it back to my desk at home yet. Next slide, please. So just a brief summary of where we are with the data, and then I have a policy update as well. Here you can see the daily COVID case rate for the county going back to the very end of May. And the main takeaway is that over the past 2 months, we have seen a steady decline in that daily reported case rate. There has been some drop in testing, reported testing during that time, but not enough to explain this. We think this decline is real, and it reflects the overall trend, although it doesn't reflect every infection in Alameda County. Next slide. And if you look at our wastewater COVID data, you see a similar trend, a steady decline over the last 2 months. There is the very last data point you can see it is popping up. Just keeping an eye on this right now, there is a fair amount of noise in our wastewater data, and so we try not to put too much stock in any one point. But we'll keep an eye on this. Could be just a back to school bump or perhaps the start of something more. Next slide. These are our daily reported hospitalizations in Alameda County. We are getting closer to having a working estimate of how many of these people are hospitalized with disease due to COVID as opposed to hospitalized for other things happening to have COVID. It's going to end up being somewhere between a third and a half, depending on when you are looking. Nevertheless, still a lot of people in the hospital. Overall, over 100 people still hospitalized on a daily basis. Intensive care unit numbers have remained low. There's a few spikes in there on the far right. In yellow, that's those are I think spurious data points. You can see the overall trend.
Dr. Moss, I don't know if it's just for me, but you seem to be cutting out a little bit.
Intensive care unit.
Lauren, let's try to reach Dr. Moss. I don't think he can hear us.
Sure. Let me try to mute him. I'm sorry. Poor thing. Okay. Did that work?
Yes.
Does anyone feel like they can step in? Would you like me to maybe Donata want to step in, or do you want to step in?
Donata, are you there?
I am here.
Okay.
I haven't looked at these slides.
We'll make it work between you and I. We'll make it work.
All right. I think I think this slide we've gone over. So let's go to the next slide and see what we got there. All right. So this shows the Alameda County COVID-19 cases by episode date. This is all the way going back to 2020 through August of 2022, and you can see we've had 5 waves of COVID, and this last wave was really a long wave that we had all the way from starting at the end of April through August. And again, based on the slide before, the case rates are really coming down and continuing to come down. And you can see that big spike we had at the beginning of the year, the Omicron. And then this wave at this current wave that we're just coming out of was the subvariants of Omicron that we saw. The next slide. All right, and then this is a map from the CDC website. This is the CDC COVID tracker, and you can always go there to see the recent updated data. But this was taken on, this looks like it says 9/13/22, but it looks like the transmission rate is substantial or high, which I think at this point we're at a low transmission level. So maybe go to the next slide. Oh, I thought there was another slide that I saw earlier. Okay, go ahead and go back.
Yeah, same. I don't know if that.
Yeah, I thought I saw another slide. There was a slide from the end of August that showed a high transmission rates, and then the current transmission rates were either low or moderate. So we'll take a look at that again to see if those dates are accurate. But go ahead and go to the next slide. So these are the updated epidemic data key points. So right now we're at 11.6 cases per 100,000 residents per day. So that has continued to come down just a little bit. 6.2% test positivity. I think a week ago we were about 7%. So that continues to come down. Okay, thanks, Nitu. Nitu just said, I think Nick wanted to show the case rates continue to be high even when the community levels are showing low. So I will, hopefully Nick can come back on and he can go back to that slide. Right now, we are still reporting quite a few lab tests per day, 4,200. And as Nick mentioned earlier, hospitalizations, there were a couple of peaks towards the end of August, early September. We have 110 hospitalized and 16 in the ICU, 151 deaths since April 1st. And here it says Alameda County CDC low community level. So that's what I remember seeing when I looked at the CDC map. And again, you can visit our dashboard for up-to-date data on a regular basis. Next slide. All right, the state health order updates. Is Nick back on? This is hot off the press. So I'm going to go ahead and read this and hopefully Nick can come back on. But there was an update today to the state health officer order update. So the state requirements to test certain unvaccinated workers is going to be changing this weekend, starting on 9/17. The information just came out today from the state. So weekly testing is no longer required for unvaccinated workers in K through 12 schools, shelters, dental offices, adult day programs, and non-medical corrections. Vaccination and boosting is still required for workers in healthcare, correctional healthcare, home health, licensed adults, residential facilities, so those sensitive settings. But weekly testing is no longer required for workers with medical or religious exemptions, and skilled nursing facilities are still subject to certain federal testing requirements. So those are those that are under CMS. Masks are still required by the state in high-risk congregate settings, and vaccination and boosting remain the best defense against COVID-19. So as you all know, we just received our bivalent boosters over the last 2 weeks. We have both Pfizer and Moderna available. Sarah, next, another slide.
It looks like Dr. Moss is back.
Oh,
and
okay.
we can see you now.
Yeah, apologies,
All right.
everyone. It's Tuesday. It's a tricky evening for me. Thank you for covering Donata, and I know you covered this slide, and I believe this is my last slide. So I'm just happy to, if we're going to do questions about this, happy to field that, or if we want to save those for later, I'm available now.
I think we have time for at least 1 or 2 questions, Dr. Moss.
Okay.
And I see one in, at least in the chat, from Dr. Rhodes asking if this is good news to stop testing people who are at higher risk of getting infected and dying. Does that mean no mitigation? Is that the plan?
The state's rationale is that we have high vaccination rates, that screening testing under current guidance, and it makes sense if you look at where I think people in this group know if vaccinated people can get and spread COVID. Screening testing programs should not be focused on, shouldn't be based on people's vaccination status. So that is the state's rationale for this, and the state maintains mask requirements, which are probably a more effective prevention tool, at least in my opinion, in many, but not all of these settings. And that is certainly, I think, more stringent than what you see in a lot of places. So, yes, I think there's an argument to be made that you should continue screening testing in high-risk settings for everybody, but that wasn't what these orders did. I think the role of screening testing is probably more important in higher risk settings and at times of higher COVID transmission, but I'm not aware that anybody has identified clear thresholds for when they should go on and off.
I'm sorry, can I just do a quick follow on and ask the question, as we try to talk to people about like, why should you get vaccinated, right? Like some of the things that we actually point to is that even though people who are vaccinated and who got infected, the ratio of people who are vaccinated who get infected to those who are unvaccinated and get infected is like 2 or 3 times. Right. And it's kind of consistently been that. And then when we look at deaths, obviously there's a huge discrepancy. So it's kind of hard to use the argument that, and I know this is the state, so it's not really directed at anybody here, but it's kind of hard to use those as arguments for why vaccination is important, but then pretend like people who are unvaccinated in settings that are somewhat congregate, classrooms are congregate settings. I mean, you're not living there, but it's definitely a lot of people in a small space, that they're not potentially at higher risk. You see what I'm saying? Like we can't kind of have it both ways. I think it makes it difficult for the conversations that you're trying to have with people about why it would be important to get vaccinated. Like it elevates the importance of vaccination, but this idea of like, we don't need to test you because it's all okay, it kind of goes using that as a reason not to test. It makes it, I think, hard to have it be a cogent argument to convince people to get vaccinated.
Yeah, I mean, I think there's a lot that is challenging when we change COVID policy, and this is no exception. I think that the strongest argument for vaccine is that it prevents severe disease, and I think these were complicated policies for a number of reasons, and flawed policies. And but I think your overall point, Dr. Rhodes, is a good one. That this is a lowering of a level of protection that was previously in place across a number of settings. And we're not really, I think the way that we're talking about it doesn't capture the full scope of that. I'm not sure if I really captured your comments, but doing my best.
No, yeah, thank you. I appreciate your response.
I see Aaron has his hand up as well.
And this will probably be my last comment because we do have to, we have some important conversations to get to. Sorry about that.
No problem. I'm sorry. Can I ask a question or can I not? Or can I not?
Yes, Aaron. Yeah, you can.
Okay, I'll be quick. So I guess I'm wondering if there's any suggestions about, as an employer, how do you hold staff accountable? If on one end we're mandating staff who are in the medical field or in these settings to take the vaccine, and on the other, if they have a medical or religious exemption, they no longer have to do weekly testing. So it kind of creates an issue. So I'm wondering if anyone has any suggestions or if that's been thought through. So that's one thing that came up for me.
You know, organizations can set their own requirements, but you know, without the state's orders, I know that it's a different conversation with staff, and it just they're you know, I don't mean to pretend that it's the same thing, but certainly organizations are able to continue to require vaccination, continue to require testing, or some combination. The medical and religious exemptions, you know, I'm not an attorney. I think there are some legal arguments for why those are in place. But tying testing, screening testing to vaccination status, I mean, acknowledging, you know, Dr. Rhodes' input before, I think there are some potential issues with that particular strategy. And, you know, whatever the, I mean, I think that, you know, I don't speak for the state, but I think it is tricky to balance these different factors out, especially as the conditions of the pandemic and our understanding of these tools evolves. And so I'm happy to try to address questions in the chat, or you know, hopefully we'll find other forums to talk about these topics. I know there's a lot of interest.
Thank you. Thank you. And there will be an opportunity to ask additional questions. And we will also, as Dr. Moss pointed out, we will try to address some of the questions that we were not able to answer through the chat. The next item on the I'm discombobulated. I'd like to turn this over to, is it Julie? Are you there?
Yes. Oops, am I, okay, yeah, I'm not muted. All right, thank you.
All right.
All right, so thank you, everyone. I'm basically here, I'm going to make a transition so that we can move into breakout groups, because I think one of the important parts of this meeting is to be able to get your thoughts and your input. First, I just want to do a follow-up from our last meeting, and I wanted to thank everybody for all of your input to the COVID strategic plan. We've taken your comments. Last meeting, we reported back what we heard and what we're doing to incorporate your comments into the strategies that we're moving forward. And the plan itself is in the final touch-up stages, and we'll be posting that within the next several weeks. So you can look for that, and we'll be sending an email out to everybody in this group with a link so that you can see the new strategic plan. So basically, I very much want to thank you for your input. So now moving into, to sort of set us up for the breakout groups, there's two areas that we selected that we know can have a significant impact in it protecting the health of the public, and that's the new bivalent boosters that are coming out, as well as the new treatments or the therapeutics. So what we're going to do is break you into two breakout groups, and for 15 minutes each, and then we're going to swap. So we're going to have a chance to get your input into both of these topics about how we can make these most effective to our communities. So what I want to do right now to set this up, I've asked Dr. Moss, he's going to give just a very brief update on the new bivalent booster and to talk about that. So this is a good sort of lead into that conversation of some of the points that were made that people are reluctant to get boosters. We're anticipating there may be some challenges in getting people to pick up on this. So he'll cover that, and Dr. Nielsen will be giving a brief update on the treatments that are currently available. We know that there is some misinformation out there, but mostly we want to get the information out. I think what we found a lot is that people are not always aware of what treatments are available if you do get COVID. And so we'll be talking about what's available and then breaking into groups to get your input to help move those forward. So with that, let me turn it over back to Dr. Moss. I want to cover the boosters.
Thank you. So just very brief, this is a big topic, but the updated Pfizer and Moderna boosters were authorized by the FDA and recommended by the CDC, ACIP, and then the CDC itself. That's the CDC's expert committee, and then the CDC weighed in, and the Western States Scientific Safety Review Work Group also weighed in. The new bivalent boosters, which are boosters that cover both the original COVID variant on which the vaccines were based and the Omicron BA.4 and 5 subvariants, which are what we have circulating in Alameda County right now. Those are now recommended for anyone who is 12 and older who has been previously vaccinated. The Pfizer vaccine is authorized for people 12 and up, and Moderna for people 18 and up. These updated vaccines are not authorized for primary vaccination. So if somebody's never been vaccinated, they would still get the original vaccine. But they are the only authorized booster at this point for people 12 and older. They can be given as early as 2 months after the last vaccine dose, and they are already available. So people can get them at this time. The age group that's not covered here, so the youngest children, there's no booster yet recommended for them, kids under 5. Children 5 to 11 are recommended to have a COVID booster, but this new bivalent vaccine is not yet authorized for those age groups, so they still would get the earlier formulation, I should say. And that's it.
Okay, great, thank you. So that's our background for that. So let's move over just to raise awareness of what's happening with therapeutics. So Dr. Nielsen, take it away.
Thanks, Julie. Good evening, everyone. So as many of you know, therapeutics are another tool against COVID. So for the following slides, really, I didn't create anything new because our clinical guidance team, our really great clinical guidance team, has already developed a lot of great information, and it's really all on our website. So what you will see here are really just snapshots of what's on our website. So there are a variety of therapeutics available for COVID. And so when someone tests positive, there are FDA authorized medications available. And we really urge people to contact their medical provider if they have one. But as you can see on the right side of your screen, that there are opportunities for people who are uninsured or underinsured to receive treatment as well. We have all of our OptumServe sites have test to treat operations. So when you go on the website, this is the picture you see there is just a few sites, but when you scroll down, we have 9 mobile sites and 2 stationary sites in our county, and La Clinica is also offering that service. Next slide, please. So who should seek treatment? So really the therapeutics that are available are for high-risk patients who have mild to moderate COVID-19 illness, who are not yet hospitalized, and those who have ongoing risk of exposure to COVID-19. So that's really important to note. So it is important to act fast, however, as many of you have heard, that the oral treatments must be given within 5 days of the onset of symptoms. And then there's also treatments that must be given IV that must be started within 7 days of symptoms. So there are plenty of medications available right now, and we don't want people to wait until they get sicker to get treatment. So that's really important. Don't wait. If you tested positive, there are some options, especially if you're a high-risk patient. On the next slide. So the next slide, this is a diagram. Again, this is all on our webpage. This is a one-pager that our clinical guidance team created that gives you an overview of all of the treatments that are available for COVID-19. So you can see there are 5 therapies that are listed. Again, these are FDA authorized. Paxlovid is the main oral antiviral that is provided through our test to treat sites. And again, this one must be taken within 5 days of the start of symptoms. And it's shown, there's studies that have shown that patients who have been prescribed Paxlovid are 5 times less likely to be hospitalized and 10 times less likely to die than patients not prescribed Paxlovid. And then there's Evusheld, and I'm not going to go into the details of each of these, but Evusheld is really available for immunocompromised individuals who are not positive and have not been exposed, but would benefit from this therapy to prevent infection. So that's really important. And then there's also remdesivir, we have bebtelovimab, and also molnupiravir that are available depending on the clinical circumstances of the individual. So again, all of these treatments are available now. Next slide. So there's a few things that are actually right now happening. We have Highland Hospital who is able to take a walk-in test to treat patients. As I already mentioned, we have the OptumServe sites that we're coordinating closely with. And then recently we've added, we started at this at the, I believe the end of June, we have worksite labs that we are deploying, coordinating with them to go to residential care facilities for the elderly and adult residential facilities to test the clients there, as well as provide them with treatment if they're indicated. And then of course, you are probably aware that we still have our inquiries line that's live. They can assist you with all kinds of things. If you have questions about treatments, how soon to get treatment, different kinds of treatment options, what I've mentioned, where can you get treatment? So there's lots of different options there on our website. The phone number is there, and the email is a good way for us to, for people to reach information about COVID treatments. And on the next slide, these are some of the other activities that we're doing right now. So access to treatments for underserved communities work group. So we meet on a regular basis, on a weekly basis. And then we also are coordinating with Alameda Health System for a future telemedicine option, in addition to their walk-in option. We also have a therapeutics coordinator, Dr. Prarthana Joshi, who's on the call today with us. And we're really grateful to have her to coordinate all of our therapeutics for our county. And then we also have a treatment education outreach group that calls people who are cases. And I'm going to talk about that in one more slide after this. And then under development also, we're trying to see if we can also provide a telemedicine line through our public health department. Okay, next slide. So our treatment education outreach pilot, so this started at the end of June, and we are still collecting data that we'll be sharing with you in the next month or so. But we have so far made calls to residents, about over 570 residents who tested positive that are over age 50 or older in priority zip codes. So we're using vaccine equity metric quartiles 1 and 2, which correlate closely with our health equity metrics, our HPI quartiles. So we try to reach newly positive residents. It's a very short treatment window. If you remember, it's within 5 days they need to start the treatment. So we call people who are within the 3 to 4 days of having tested positive. And then so far what we've seen is that about 50% of cases of these 570, about 50% have both answered and agreed to an interview with us. And then 50% of the interviewees knew that treatment was available. And then approximately 25% of those plan to seek treatment as a result of our outreach. So it's a small number, but we are making a difference, and we are able to reach people to make sure they understand that there are treatments available. So just to sum it up on the last slide, just a reminder that you can go to our webpage, you can call our inquiries line, and you can send an email if you have any questions about access to treatments. And that's my last slide. Thank you.
Okay, thank you. So I think at this point, what we want to do is we're going to split the group into 2 and move into breakout groups. We've got some questions prepared, and we'd like to get your input on how we can best make these prevention measures available to our community, these treatment measures. So I think, Lauren, you could do your magic.
Sure. Thanks, Julie. So I've randomly assigned folks to either stay in this room or go to the one breakout room. If you need ASL interpretation or Spanish language, and I've accidentally put you in the other room, just come back to this room. All of our interpreters will be in the main session here. After you don't have to go anywhere. And after 15 minutes, I will move switch the facilitators into the other rooms. So with that, I'm going to open the one room and half the group's going to move there and the others will stay here. Here we go.
Okay, I think the transition has happened successfully. It's great. It's the closest thing to teleporting I think we'll ever do. All right, so with this, let me see if I need to pull up.
Hi, I just
Yeah.
I'm Narcy, so I need to leave because I have another things to do on my school.
Thank you
Oh.
so much for being here, Narcy.
Thank you.
Okay, then should I go ahead, Lauren, and share screen for the Jamboard?
All you.
And does everyone have access to the Jamboard?
I will throw that in the chat and I'm going to go into the other room and put that in there. As a reminder, this is the booster Jamboard, correct?
Yes, that's correct.
Okay.
So let me share screen, and I think this is the correct, here we go. Can everyone see what's on the Jamboard, sort of a gridded screen?
Yes, and you might want to remind people how to use a Jamboard.
Okay, so what I'd like to do, this is the first question that I have, and which is really around the bivalent boosters. We'd like to know what you're hearing, what concerns are from the community. And we've heard a couple of those in the earlier today and at the beginning of the meeting. And for those of you, it would be great if you could you can unmute and speak up. And also, if you look at the screen over right underneath the big arrow, there's this sticky note button. You can open up a sticky note and say, you could put in a comment, and then you can save it to the screen. You can pick any color you like, and that way we can then we can capture comments on the screen itself. So please feel free to use these. The link to this is in the chat right now. So please feel free to open it up and add your own comments to the board. All right, with that, so I'd like to open it up to the floor. And our first question, we have several questions, but just what are you hearing about the bivalent booster? And yeah, if you could let us know, what are our communities telling us? Bruce, hi.
Well, I think what I'm hearing, and it's interesting how many phone calls and emails I've gotten, has to do with what everybody is hearing, and that is how safe are these since the testing's been on non-humans, although a few humans have been tested, mainly rodents, mice, etc. Have been the test products. I understand that that's the same thing that has to do with the flu shots, but that's still very uncomfortable for practically everybody who with whom I have spoken. And it does have to do with safety, but it's more than that. There's been so many different feelings about what to do about the COVID shots themselves that this has put an extra level of, are you sure? Now here comes my big thing. Now they're recommending also having a flu shot at the same time. And that's also brought in a lot of uncomfortable questions to me. And I mean, I have this in here, but I was really upset with, I am saying his name wrong, Ashish Jha, his statement, he's the one who's a statement in Washington, D.C., who said, God gave us two arms, and therefore you should get the two shots, the COVID booster, Omicron booster, and your flu shot at the same time. And I think bringing religion into that was something else that people also mentioned to me that they had seen on the internet. We have enough problems as it is trying to convince people of things. And now when you throw religion into it too, that's really difficult and brings up another bunch of questions. That's it.
Great, thank you, Bruce. Great, we'd love to hear from any other partners or folks about what are you hearing from your communities about the new booster? Kim, I see your hand.
Yeah, just a general skepticism, I think in part because every time we get a new intervention, we act like this is the thing that's going to end the pandemic. And it doesn't get put, I think into the kind of perspective that allows people to feel trust in the predictions that have been made in the past. So I think some of what I've heard is like, I've already been boosted. Why do I need this one? So there is the response that it is targeted for the current variant, but then the next savvy question is this going to cover me for when the next variant comes in the winter? So I think part of it is a loss of confidence in I would say like public health, healthcare, et cetera. And that erosion has been ongoing since the beginning of the pandemic, but now we're at a kind of a crucial point where we actually need to leverage that authority or influence, and there's not much equity in the bank to draw on.
Okay. Just put erosion of trust, and feel free to jump onto this, and you can add or change any of these. Okay, are there other thoughts? Anything else you're hearing? If not, I'll go to the next question. So really the next question is, what can we do to increase uptake? And how do you think, what do you think about this rollout, and what should we keep in mind as we introduce the new boosters and move forward with this? We have a quiet group today.
We do.
Some folks,
Dr. Bruce.
Okay, it's me again. I think if we can make it as simple as possible, increasing uptake, there's definitely a probability you may need a second booster, and that should be brought up as part of your initial discussion. I can't think of very many things that are really going to help, since we've gone through so much with the first series with all of the questions that are there. I think also, are the variants going to change again, and are we going to need a totally new type of booster, and how fast is that going to come has been one of the questions somebody asked me. Why is the 4 or 5 working now, and are we going to get an 8, 9? So that's about it. It's still, again, a problem with messaging and making sure that you don't make people feel uncomfortable.
Okay.
Julie, I don't know if you captured this from Dr. Rhodes' comment about the skepticism, but in the comment was also a recommendation to around
Okay.
how we should consider talking about this in terms of it's not a done deal. You know what I mean? And so we have to really think about how we can be pretty forthcoming about and transparent about, okay, here's what we think, kind of thing, because people are going to do what they're going to do. And so it probably does not harm us. And of course, I'm putting lots more words in your mouth, Kim, but to talk about what we think is probably going to happen, you know, kind of thing. Uh-oh, I didn't do that. Put my thumbs up next to me. I didn't even do that. Okay. So at any rate, yeah, so she said something like that. So I just wanted to pull that out, whatever her recommendation out of her comment to make sure that it's in here, that we need to figure out a way of talking about this so that every time we come up, every time there's a new vaccine, a new booster, we're not suggesting, oh, now it's over kind of thing. Like, do we really think that? And the answer is probably no, you know? And so we need to be more forthcoming about what we think is going to be realistically, here's what we really think is going to happen kind of thing.
Okay.
Even if that means telling people, yes, we do honestly think that if it continues to mutate, which it likely will, and if we believe that the vaccines will provide better and better protection based on the variant, yes. And if we don't see any downsides, you know, to getting boosters like we get flu shot on a regular basis, then yes, we are headed in that direction, something like that. And I don't want to step outside of, you know, my lane. I'm not a doctor, that kind of thing. But if that is what we believe is going to be the case, we need to be saying that so that people kind of know what to expect and they're not always surprised, kind of like, oh, something new, that kind of thing.
Right.
And I want
Okay.
to,
Yeah.
I'm sorry, I just want to appreciate you, Kimmy, for elevating that because, and I don't think the thing about you being outside your lane, we're not trying to communicate to doctors. We're trying to communicate to regular folks. And if we don't have the, we no longer have this follow the science credibility because we did a flip flop on masking. We changed the definition of high community transmission, right? We've said it's milder, even though we're actually having more deaths than we had during Delta, which was our other, you know, our most recent summer surge. So I think like what you're speaking to is humility. And I think we need to take a dose of that at this, like, if we do it now, I think people might be more willing to listen, that we're all kind of figuring it out together versus follow the science, because we've said follow the science. And so far we're year 3 of this pandemic.
Right.
Okay.
Thanks, Julie.
All right. Thank you. Now, those are really important comments. Are there other thoughts on this? And we'll make these larger and more available. And again, feel free for any of you to add to this. Let me just see. Let me ask you, so we've got just a few more minutes in this breakout group in terms of what would you like to see? What would our goals, what would you like to see as our goals for this new booster coming out? Right now, I think we've set our sights. We have been doing, going to those areas that have the lowest vaccination and highest transmission rates. So we've continued our equity strategy, or to put equity at the center of our strategy. Would you like to see, the goal be, well, not 100%, 90%? Should we be striving for 80%? Or would you like to see, do you think we need to set different kinds of goals for this rollout? And I just wonder if anyone else.
And we apologize. This particular group has more of us and the interpreters than CAG members. So of course, that means we're leaning harder on those of you in the group that don't work for the department and are not interpreters.
Right, I know I've been searching around to say, okay, who is not with the department right now? So.
Our technology magic didn't quite work this time.
Yes. Thanks all. So with that, I'm going to pluck Julie and Dr. Moss and drop you into the other room and then go in and pluck the others out and bring them in here. So just want to give you guys a heads up before I just completely steal them.
Okay.
So I'm going to do that now.
Well, thank you. I mean, I think some of the points that were brought up were really good. Does anyone else want to have any other thoughts, ideas that you want to put forward before we switch the next group?
Like I kind of need to pluck you, Julie.
Okay, very good. Thank you, everyone.
Thank you. Thanks. All right. Folks, someone will be here soon. Let me go into the other room and grab them.
Kimmy,
Yes.
you were great. Really, you hit it on the nose.
Thank you, thank you, thank you. Okay, so our facilitator is winding up their last comment. The other group was much larger than our group, so so just one moment. And our new facilitator will be joining us. Donata, there you are.
Oh, hello, everyone. How are you?
Good. Go ahead.
All right, so I'm going to go ahead and share my screen. So we're going to be talking about therapeutics, and I have 2 questions that I will share with you. One moment. So we already got some really good comments from the previous session. Can you see my screen? Not sure if you can see.
Yep, we can see it.
Okay, great. So I'm going to go ahead and say both questions because we did not have enough time to go over both of them. Let me see if I can get rid of this right here. Okay, so the first question is, when people get COVID, do they know what to do? For example, do they know about eligibility, who to contact? Do they know about testing sites and when they can go back to work? And what are you hearing? What concerns are you hearing from the community about access to treatments when people get COVID? And then the second question is, what can we do to increase awareness and uptake of therapeutics, and what should we keep in mind? So I just want to have both of those questions up front because we spent a lot of time here at the beginning. You can see a few comments. I will share a few things that definitely there was confusion and not people really don't know how to get access to treatment. Some people say they want a treatment and then they were told by their providers they didn't qualify, even though they felt like they did. There were also some comments related to people who don't have insurance or are underinsured. They were more likely to get told that they didn't qualify because they didn't have a history of immunocompromised condition, even though they felt their bodies needed some kind of treatment. So those were some of the comments that came up. And then delivery options were something that was important as well that came up from the community, because some people don't really have the access to transportation, or for other reasons they weren't able to pick up the medication. So those were a few comments, and you can read some of the others here, but I'm happy to take hands. And actually, let me just go here, see if there's anything else. There was some talk about confusion and mistrust around messaging about treatments. Yeah, and talked about the eligibility and just knowing where to go to get treatments was a concern, and there needs to be more messaging. So I'm happy to take questions, or if anyone wants to provide comment, and I will go ahead and write some notes. And if anyone would like to do their own notes, you can grab this little icon here, and then a little sticky note, you can post that yourself. So does anyone want to start us off? I think I can. Any other things that anyone has heard from the community about access to treatments, or questions about treatment? Do they know about treatments that are available?
It would be great.
Go ahead.
Oh, I was going to say, it would be great to hear from some those in the group that haven't spoken. Everyone here is not from the county and a translator. We had mentioned that it was a little lopsided earlier, Janata.
Okay.
But I think Dr. Gok raised his hand though.
Yeah, I did. The mouth is speaking again. I think you've been doing a really good job, and I'm not just saying that to say it. Have you looked at other ways of having communications? How many of the internet type issues have you used that people might have? Have you talked to the teenagers who love going through the internet and doing messaging, and also telling them how great they are for helping save people's lives to make it a positive for them? The other things I know that have been done through a lot of workshops, etc. But what you're looking for are the main people in the community who don't have the ability to go to workshops to hear anything. They're just working here and there as much as they can. Have you spread these pieces of information to many of the fast food restaurants, saying, would you have this sitting on your checkout place? Have you used the places that are arcades that people go to? A lot of, let's say, alcoholic beverage places that are available. Just having the messages there and having something at the very beginning of it on the first page that says, this is how you can get in touch with somebody. This could actually save your life or the life of somebody you care about. Don't put down the life of somebody you love. Put down somebody you really care about. You want to be really careful again with messaging, because that's going to either get you where you want to go, or it's going to be exactly the opposite, because there's certain, prime words that can do that. And if you talk to, say, the teenage groups, if you talk to the young adult groups, ask for what words and what types of messaging would they kind of think would be the best versus what the county thinks would be the best, because we talk different languages. And that's something that I don't think a lot of people really understand or put into their decisions as to how they have outcomes as to what their actual message will bring to them.
Thank you for that.
I'll help you, Donata. Claudia Campos, and then Kim Rhodes.
Hi all, thank you. One other concern that I think I've seen is when people get COVID, they are still confused about quarantine and isolation periods. And specifically because the CDC has given that like split between the full 10-day period where 5, they have to stay home and wear the mask. But after 5, if they're no longer having any symptoms, then they can go out, but have to continue wearing a mask. That's still very confusing amongst the community. And also the fact that their employers are still giving different messaging. For example, requiring for people in the community to return with a negative COVID test, when messaging has also said that it's not recommended for people to retest once they've tested positive, because they can continue to test positive for an X amount of months. And so that is very confusing as far as people trusting whether they should say or not that they've tested positive to avoid losing time from work.
Thank you for that.
Dr. Rhodes?
Yeah, I think my comments already got covered. I mean, I just think the messaging has been so jumbled and we've made so many changes about how we isolate and quarantine or don't isolate. And then I also think just sprinkle on the masking piece, and the messaging ends up being, you know, if you have COVID, do whatever you think is right. Like if you feel okay, then, you know, go on about your business. And I do think there's an opportunity. I mean, in San Francisco, we did create a very specific card that has a workflow on it, if you will. It's like a decision tree about what you do if you get exposed or if you test positive. And so like telling people what the cadence of testing is. So it's reinforced by having something in front of you. So then you don't have to guess, what is the CDC saying this week? But I haven't really seen that in Alameda County. And then it also includes a warm line for getting Paxlovid, which I mean, I think we're going to get to that. I definitely have more to say about that. But I don't think we've done that very intentional messaging to be very, just very explicit and literal. Like, what do you do?
Thank you for that.
Yeah, that's a great idea.
All right. Any other hands? Any other comments?
Let's see if I see anyone else. Donata? Don't.
Let me go to the other question in case there's anything there that anyone would like to comment on. So what can we do to increase awareness? We talked about that a little bit, about therapeutics, and what should we keep in mind? I think we covered a little bit of that as well.
Can I add something here, Donata? I think that one of the things that I know we've talked about is talk to your provider, but what I'm hearing from people is that the information from the provider is uneven, you know, so it's not really evened out currently. And so I think it's important for us to make sure that, and so I'll just speak as if I got COVID, I would want to be able to go somewhere and get accurate information about what I need to do. I don't want to have to depend on my healthcare provider to tell me. I want to go in asking like, okay, can I get this? Am I eligible for it? In case they don't ask me, in case they don't tell me, you know? And so I think it's important for us to make sure that people are armed with their own information to better than engage providers, because right now it's really uneven. There are people who are getting therapeutics who are not necessarily high risk. People who are high risk aren't getting it. So,
yeah,
you know,
that's a good point. Very good.
I like that decision tree. Dr.
Yeah,
Rose?
I can share that. I can share that card with you. I have been trying to ask, get permission from our partner who produces those in San Francisco to strip them so that they still have their branding, but that the QR code on the back takes you to something that is the, the other Emoja locations, right? In terms of resources and like what the hotline number would be. So so one thing I will say is that I think a lot of people wait to see if they're going to have a severe case. If they're going to need, they have this idea that you hit some threshold of feeling bad where you need Paxlovid, but obviously if you wait for that, you may be at day 5 from start of symptoms and then you're outside of the window. There are other options, but I don't think that, I haven't seen the pharmacy data, but I don't think that the other options are widely known about, or even for primary care providers, if they even know where to send somebody to get monoclonals, for example. The other thing is, for the people who don't have a primary care provider, how do you get to a primary care provider in 5 days of symptoms?
Right.
That makes it really hard. And I think the last thing I'll say is, well, there's 2 things, but the last thing I'll say about like the participant experience or the patient experience is having to wait. If you do have a primary care provider, I mean, maybe some systems are run more smoothly than others, but actually trying to get an appointment with your primary care provider like puts some hurdles in place. Then the last thing is I think we need to also be, and I don't know if you have a question about this, but Paxlovid is about to not be free. And that's going to be a problem. And you can kind of hear it in the language of how we're dealing with COVID is we have the tools, and those tools are at your primary care provider's place. And so then we're right back to, the communities who have had the highest infection rates and had the worst outcomes tend to be the same folks who have the, disparities in other diseases and have diminished access to, traditional ways of getting medication. So the fact that it's going to start to cost money puts yet another layer of a barrier on it. So I think we need to think outside the box. Like, you need something that is structurally different than what we currently have. And then I do, for folks in our network, I prescribe Paxlovid. And I will just tell you, wasn't easy the first time I did it. I had to call like 3 different pharmacies. But the reason that I think people who know that they can get it are willing to take it is because it's going to be easy for them. And so test to treat's a fabulous concept. I don't think anybody's talking about the nitty gritty, which is to have Paxlovid on site. You have to have some pharmacy capacity, but I could see very easily, all of the community partners who are out there on the front lines, giving shots, doing tests, taking care of people. Like, why can't we find alternative ways to get Paxlovid into their hands and have it right on site? So I just want to say, I don't think the current tools that we have and the current structures that we have, I don't think you're going to be able to get around them and make it all better. I think we actually just need a different kind of system.
Thank you for that. Yeah.
This is Dr. Spanders. I just want to say something. I agree with the problem of the government funding going away, and also some of these therapeutics being pushed into the commercial markets and not being free any longer. One of the examples is bebtelovimab, which is a monoclonal antibody, but people are trying to look at that, still funding it through Medicare and Medi-Cal. Also, some other funds are being looked at to help the uninsured. But yes, that could be a problem. And Paxlovid may eventually next year possibly also be put into the commercial market too. But hopefully there will be some coverage from other areas, but that could be a problem.
Thank you. Thank you. And we apologize for having to rush and quickly pivot, but we wanted to get as much as we can from Dr. Dunn in terms of Mpox update. I want to thank everyone who contributed to our jam boards, and of course, we will integrate this in and bring this information back to you and to share back how your input has helped change our operation. Dr. Dunn, thank you.
Hi, everybody. Well, that was a great conversation. So I'm going to provide Mpox outbreak updates. Next slide, please. And so this is the most recent update on Mpox cases in Alameda County as of the 12th of this month. There have been 201 cases. As reported in earlier meetings, Alameda County's the percentage that are young people remains high, much like other settings. Most of the cases have identified as gay or bisexual men or other men who have sex with men or transgender men or women. But it's important to note anyone can get Mpox with exposures. 40% of the cases in Alameda County are Hispanic, Latinx, and 24% are Black African Americans, and 28% are people living with HIV. And some of the information on the global numbers, as well as the US and California numbers, are in the slide at the bottom. Next slide, please. So I wanted to provide a summary on the Mpox community vaccination. The Mpox or monkeypox vaccine is called Jynneos. It is FDA approved to prevent Mpox. It is a 2-dose vaccine series. The second dose is at least 28 days after the first dose. And at this point of the epidemic, we are recommending administration intradermally, except in certain circumstances. Those circumstances include in persons under the age of 18 or persons that have a history of keloids. It's important to note that intradermal administration is as immunogenic, it actually produces equivalent immune response to doses given subcutaneously. The updated eligibility to reach most impacted communities, I will share that in the next slide. Regarding vaccination in the community, we're working with over 24 healthcare partners throughout Alameda County with both in-hospital outpatient community clinics, and they have vaccine allocated for administration in those settings. We've had a number of county pods, vaccine pods. We most recently had vaccination at Oakland Pride with 553 first and second doses and 504 first and second doses at Pride Fest. And we are still participating in the regional pods at Steamworks every Wednesday. I would like to point to our website. It's on the next slide for all the updated information on locations of vaccine. Just to highlight the Mpox vaccine eligibility, which was recently changed, includes gay and bisexual men, transgender people, men who have sex with men, or transgender people, sex workers of any sexual orientation or gender identity, close contacts of persons with monkeypox within the last 14 days, persons who've had close contact with others at a venue or event in which Mpox case was identified, laboratory workers who routinely perform Mpox virus testing, and clinicians who've had high-risk occupational exposure. And again, pointing to the website that was recently updated on the bottom right. Next slide, please. So what are the Mpox public health response priorities? Primarily collaborating with community partners, such as yourselves, and providing health education and guidance, translation of materials that are easy to understand and reach the right audiences. We are working to identify cases in a timely manner and conduct contact tracing. And timely referral of contacts is important to prevent Mpox and receive vaccination. We also are supporting treatment in community settings, especially for the most severe cases. We are prioritizing prevention of transmission, and that includes isolation of persons with Mpox and vaccination of close contacts. And we know that health disparities that exist are often magnified during emergencies and outbreaks. And this is was demonstrated clearly during COVID. And our monkeypox response efforts are committed to health equity. And we are aiming to end stigma and discrimination based on socioeconomic status, age, race, sexual orientation, and gender identity. And we recommend sensitive evidence-based care that is gender and sexual orientation affirming. Next slide, please. And highlighted on this slide are our MPOX risk reduction messages that have been developed and were used during our Pride Fest event, working with partners such as yourself in the community. And we hope that this is helpful to use infographics for demonstrating MPOX exposure risks and certain activities. Next slide. And I'd be happy to take any questions you might have.
Because we are really at time, we want to make sure that people can ask a couple of questions if they have them, but also please drop questions in the chat. And what we will do is that we will prepare answers to questions and send them out to you if there are questions that we know we can't get to. And we apologize for running out of time. But we can answer one question, I think, if someone has one.
I think Dr. Bruce has his hand up. Go for it, Dr. Bruce. You're muted.
There we go. What happens if, what do you tell them if they say, now that I've had the shots, that means I can have regular sex again because I'm protected?
So the vaccine, the recommendations for the vaccine is 2 doses. Are you saying what happens when they get 2 doses?
I've got my second dose now. Does that mean I can have sex with no worries at all with any people I want to have sex with?
Yeah, one of the things that's really important that we're communicating to folks that have gotten the vaccine is there are still a lot of things we need to learn about vaccine effectiveness and the long-term protection of the vaccine. This is an unusual and new outbreak. The magnitude and the way it's being transmitted, and we will be learning more and more about the duration of protection and how well it protects for future exposures. So at this point, I think one of the things that's really important is what we know and what we don't know about the vaccine, and that is certainly one of them.
Okay. That was one of the things I forgot to ask about COVID very quickly, because I've had people ask me, since I've had my 2 COVID shots, my boosters, etc., I'm not going to get it, right? I don't have to worry about doing anything and protecting myself. So it's the same idea. That was why I asked that question.
Yeah,
and HIV, syphilis, hepatitis, and all the other things you can get. Sorry.
Yes, exactly. No, I think that was a good point that Joan made in the chat is, with sexual activity, certainly there's a myriad of different potential risks. And yes, condoms, PrEP for persons at risk for HIV PrEP, I should say, and other measures to prevent other infections. And one thing we're seeing in Alameda County is many persons also have concordant or coinciding sexually transmitted infections with monkeypox. Over.
All right. Again, apologies for going over. Thank you so much for all of your feedback, all of your questions. Please drop questions in the chat as we're all exiting. If you have some that you were not able to ask, and we will get the answers back to you. Again, Have a wonderful evening. Thank you so much for all of your input and your partnership and your continued partnership with us in the work that we're doing together. And thank you, everyone. Good night.
Thank you.
Thank you.
Thank you and good night.
Good to see you, Winnie Knowles.
Good to see you too, Lauren. Is that a background picture from your vacation?
Yes, it is. This is Banff, the town of
Nice.
Banff. Banff.
Nice.
Banff.